I'm Sydney Saunders, a primary care pharmacist here in Dawson Creek, and tonight we will be talking about hypertension in older adults. So just as disclosure, I'm employed by Northern Health. For learning objectives, tonight we will briefly discuss the evidence for hypertension targets in older adults, briefly discuss the clinical considerations that might impact choice in older adults, as well as consider other medication classes that might impact hypertension control. So very quickly, just the diagnosis of hypertension. It's noted in the guidelines now that 24-hour ambulatory blood pressure monitors or a series of home blood pressure measurements is preferred for diagnosis of hypertension. As an alternative, it can be done of a set of in-office measurements, and that's recommended to be done over a number of visits, not just 1 to 2. Automated is much preferred over manual due to the accuracy of the devices. And we want to ensure that patients, especially when checking their blood pressures at home, are ensuring appropriate technique. So based on this Hypertension Canada infographic here, we want to make sure that the patient's sitting with the supported back, their feet flat on the floor, their arms supported, and no talking or movement during the measurements. We always want to assess for orthostatic hypotension, and we want to make sure that we do that assessment prior to starting medications, not waiting for the symptoms to arise and trying to manage it once medications have been started. And we would do that by measuring the blood pressure supine first, and then standing or sitting a few minutes after. So we want to think of possible causes of hypertension as well before jumping to medications. So sleep apnea is a big cause in our older adults. And oftentimes patients have a CPAP. We want to make sure that they're using it and using it properly before we jump to hypertension treatment. Always considering thyroid disease as well. I've seen quite a number of patients who were treating for hypothyroidism with levothyroxine, and they are being overdosed, essentially making them hyperthyroid, and just making sure that we don't put them at increased cardiovascular risk from that. We want to assess their adherence, because oftentimes when a patient's already on quite a number of medications, non-adherence is more likely the cause than resistant hypertension. Considering alcohol, renal disease, as well as medications can have a big impact on that. So our biggest culprit would be NSAIDs, typically over the counter, decongestants, so both oral and nasal, any long-term steroid use, certain antidepressants like venlafaxine or bupropion, hormone replacement therapy, and herbal products, things often marketed as energy supplements or weight loss supplements, often contain ephedrine, which can negatively impact that blood pressure. Patients may not consider most of these as medications, so it's important to ask them about their over-the-counter use, specifically asking about NSAIDs, cough and cold medications, and things like that. And before treating hypertension, we want to discontinue any medications that might be negatively impacting that blood pressure control before we start therapy. So we always hear numbers thrown around, less than 140 over 90. There are all kinds of different guidelines out there. But our question tonight is this applicable to older adults? So when we take a look at the guidelines, there's a wide variation. So our Canadian guidelines, the CHEP guidelines, recommend less than 140 over 90, but they do state that if your patient is over the age of 50, they have cardiovascular disease, a Framingham risk score greater than 15%, CKD, or they're over the age of 75, they suggest targeting a systolic blood pressure of less than 120. Our American colleagues say less than 130 over 80 for everybody across the board. Another American association does actually have a recommendation for people over the age of 60 of a systolic less than 150, but they say you can consider less than 140 for high cardiovascular risk or history of stroke. Our European guidelines say 130 to 139 systolic, and they specifically do state for people over the age of 65. And it should be noted that they actually have a statement that we should not be targeting less than 120 because of that balance of benefits and harms. And finally, our BC guidelines recommend less than 145 over 85. So with all of this information, makes us question, we're all using the same evidence and coming to very different conclusions. And it is overwhelming when we try to sift through this to come up with recommendations for our patients. So when we're thinking about treatment, we also have to consider the risks that can come along with that. There have been studies that have shown this J-shaped curve for cardiovascular risk and morbidity and mortality, which essentially shows us that untreated hypertension can lead to cardiovascular issues, but so can overtreated when the diastolic and systolic values are too low. So again, while this is a hot topic and quite debatable, it reminds us to keep that in the back of our mind when we're assessing treatment to make sure that we don't overdo it. And then we throw another curveball in there that your patient also has diabetes, and there's quite a wide variety there as well. So Diabetes Canada recommends less than 130/80. Our American colleagues less than 140/90, but they have a clause lower for high cardiovascular risk patients, as well as our European colleagues have that same 130/139 systolic for people over the age of 65. Again, very different recommendations, all based on the same evidence. So diving a little bit further into some Cochrane reviews, there was this paper published just a couple months ago, and although it's not specific to older adults, what they did was took studies that compared a lower blood pressure target of less than 135/85 with a standard of 140/160 systolic. And they found that there was no evidence to use those lower targets in hypertension and cardiovascular disease. So jumping a little bit more into our older adults, so those over the age of 60 years old, they found that blood pressure lowering drugs actually reduce death, heart attacks, and stroke. So our conclusion there is that treatment is good, but again, where is that target and where is that threshold? And jumping back a few years, looking at blood pressure targets for hypertension in older adults, they noted that at that time, there was insufficient evidence to recommend a lower blood pressure target of less than 140/90 versus a higher, less than 150/160. And again, additional trials are needed to make this conclusion. And diving into the primary literature, taking a look at the HIVET trial back in 2008, their primary outcome was fatal and non-fatal stroke. Their intervention was indapamide plus or minus perindopril to a target blood pressure of less than 150/80 versus placebo. They included patients over the age of 80 who had a systolic blood pressure of 160/199, and they excluded patients with heart failure, serum creatinine over 150, dementia, and long-term care. When looking at the results, their primary outcome for fatal and non-fatal stroke was not statistically significant, but some of the secondary causes that did have significance were reduction in all-cause mortality, heart failure, and any cardiovascular events. So our takeaways from this is that treating hypertension in the very elderly is better than placebo, but it does exclude many of our typical patients when we think of heart failure, CKD, dementia, and long-term care. And it should be noted that the patients in this trial were often a healthier population, with only about 12% having a history of cardiovascular disease. And again, even with the results of this trial, it doesn't give us an ideal blood pressure target. Jumping forward a few years to SPRINT, their primary outcome studied was a composite of MI, acute coronary syndrome, stroke, heart failure, and death from cardiovascular causes. They included patients over the age of 80 with a systolic blood pressure of 130/180 and at least one cardiovascular risk criteria. And those criteria were clinical cardiovascular disease, subclinical cardiovascular disease, CKD, a Framingham risk over 15%, or the age greater than 75. They excluded patients with diabetes, a history of stroke, heart failure, EGFR less than 20, and long-term care patients. Their intervention was intensive blood pressure targets with systolic blood pressure less than 120 versus standard of systolic less than 140. Taking a look at their results here for that primary composite endpoint, their number needed to treat that was statistically significant was 63. So there was some benefit to that lower target. But taking a look at the risks, their combined serious adverse events, as we can see here, there was no difference between the treatment groups. But when we break that down into that conditions of interest, we can see that there are pretty comparable numbers needed to harm when it comes to acute renal failure and hyponatremia and electrolyte imbalances. And we have to remember that these risks aren't benign. They can have negative effects to patients. So something to consider going forward. When we step back and look at the SPRINT trial as a whole, we really have to consider the applicability. So it excluded many of our patients that we see in our typical panels that have diabetes, heart failure, CKD, and there are statistics out there saying that if you took all of the patients in the US who had hypertension, only 17% of those would fit within this study criteria. So again, makes us think about that applicability and generalizability. And it's noted that they had quite a healthy population with low statin and aspirin use at baseline. Another thing we have to consider is the overestimation of the treatment effects. The study did finish quite early, and so it begs the question, would those benefits persist over the long term? Another thing to note is the intervention group, their systolic blood pressure only got to a mean of 121.5. So should we really be targeting a goal of less than 120 if half of the patients in this trial didn't actually achieve that goal? That could mean that there were fewer ADRs than there would actually, adverse drug reactions than there would be at lower blood pressure targets. So essentially the bottom line is more medications for intensive treatment equals more monitoring, more cost, more drug interactions, adverse drug reactions, and polypharmacy, which is essentially what we're trying to avoid, particularly in this population. So does this leave anybody else feeling like this gentleman, wondering, sifting through all of that evidence, what's the best target for my patient? So there is one thing that's clear, is that there is benefit to reducing blood pressure in elderly and older adults, but there's no one size fits all target. So we want to make sure that we individualize that target for our patients. So you can consider the cardiovascular risk, any comorbidities they may have, their frailty, existing polypharmacy, potential drug interactions, as well as cost and adherence of these treatments. And the biggest question we need to ask ourselves and ask our patients is, what do they want? We have to remember that that patient-centered care is key. So we're going to jump into patient case number 1 and have some discussion here. So this lady is a 70-year-old female. She was new to the clinic where I was working, and we were awaiting her medical records as she transferred from out of province. She was referred to myself for medication review and possible deprescribing. So because we didn't have any of her records, this was all patient reported. So she reported high blood pressure and a possible heart attack 20 years ago. Nobody had really confirmed that with her. She was on hydrochlorothiazide, olmesartan, amlodipine, metoprolol, terazosin, and furosemide PRN. She was on a mixed insulin for diabetes, rosuvastatin for dyslipidemia, triple therapy for COPD, paroxetine for her depression, mirabegron for incontinence, rabeprazole for GERD, and amitriptyline for chronic pain. When I saw her in clinic that day, her blood pressure was 106/52 with her heart rate 66. At the time, she did report occasional and mild dizziness and lightheadedness, but nothing she was overly concerned about. And again, at this time, we had no labs or investigations available. So at this point, I'm hoping to have a bit of a discussion and open it up. What would people do if this was a patient in their practice?
Certainly one thing I would do right in the outset is just check for that orthostatic hypertension, because there are a number of things here, not just the blood pressure meds, but even something like amitriptyline that could be contributing to that. So, and she does seem to be a bit symptomatic, so, and her blood pressure is a bit low. So I would first want to know that.
Absolutely, great point. Any other thoughts from the group?
She's living independently by herself?
No, I think she moved with family when she came to the province.
Oh, okay, good. Yeah, it would be nice to clean up her medication list. Like the furosemide, I would probably take away. I'm not sure why it was given PRN. And quite the list for antihypertensive, either to reduce some doses or take some away.
Absolutely. Do you have any in mind that you would target to either reduce or take out completely?
I might take away at bedtime.
Okay.
And then I would do it like per. I would get her back on a regular base and reassess her.
Okay.
And then slush it down and see how she does, and then go one by one and see what she really needs. And maybe I would keep her on she had incontinence too, so maybe the diuretic I would be a little bit careful with, and maybe she doesn't need the mirabegron if she doesn't take a diuretic too.
Absolutely. And I see Dr. Perry's comment here, really want to know what happens to her blood pressure and her heart rate when she stands up. And that's something I regret not doing the day of. That appointment was rushed, so it was something we weren't able to do, but I wished I had that information.
Mhm.
Hello.
Hello.
Yeah. Yeah. So I will also consider the blood pressure medications and then try to those ones that have no cardiovascular benefit will be the ones that we want to, review or take away while
Absolutely.
checking the blood pressure, alongside. I also want to do an EKG just because of, tryptolin, we know that has a lot of side effects, only on the heart as well as the anticholinergic effects. So it's something that you want to worry about, given in the elderly people. So I also want to review that vis-a-vis, especially with the background of heart attack. So one we want to be very careful to make sure that medication that has good cardiovascular coverage, you don't want to take them out because of the benefits.
Absolutely. Thank you for your thoughts. Keep this case in the back of your mind. We'll come back and do the conclusion with her, but we'll spend a few minutes going through choices of antihypertensives in older adults. So there are definitely things you want to choose first and things that you want to avoid. So when going to choose therapy, you want to start with lower initial doses and lower that blood pressure gradually, unless of course it's a hypertensive urgency or an emergency situation. You want to taper their therapy based on their comorbidities. Consider first-line agents like thiazides, calcium channel blockers, ACEs, and ARBs, and reserve that beta blocker only if there's another indication. Things to avoid would be alpha blockers and alpha agonists, many side effects, poor outcomes with those agents. Avoid combining the beta blocker with your non-DHP calcium channel blockers like diltiazem and verapamil because of their negative inotrope and chronotrope effects, as well as never combine an ACE and an ARB. Firstly, we'll go over thiazides. So again, they're first line, particularly in people over the age of 60 with isolated systolic hypertension, good blood pressure lowering benefits. And again, we want to start with lower doses. So chlorthalidone 12.5, hydrochlorothiazide 12.5, or indapamide 1.5. Chlorthalidone and hydrochlorothiazide are our only agents covered by Pharmacare. Indapamide is special authority. When we look at the blood pressure lowering effect, the chlorthalidone has a max lowering of systolic blood pressure at 12.5 milligram dose and your diastolic at 12.5. So we don't have to go to higher doses of these agents. When it comes to hydrochlorothiazide, you get 80% of your max blood pressure lowering at 25 milligrams, and indapamide, you get the max at 1.25. One thing that's a bit annoying with chlorthalidone is it only comes in a 50 milligram tablet. So when we're trying to get 12.5 and 25 milligram doses, this can be quite difficult. We want to caution these medications in gout, especially higher doses, as that can exacerbate the condition. And there's little efficacy at creatinine clearance or eGFR is less than 30. So that would be when we would pull these medications off. Next, looking at ACEs and ARBs, they're first line, particularly in CKD, diabetes, cardiovascular disease, recent MIs, or heart failure with reduced ejection fraction. Again, good blood lowering capabilities. When it comes to their efficacy, we have 60 to 70% of the blood pressure lowering effect with their initial doses and up to 90% lowering with half of the max doses. So again, we don't need to push these to those maximum doses to get the full effect. We want to start low and go slow and check serum creatinine and potassium with dose titrations. When it comes to Pharmacare coverage, Ramipril is the only one that's the only ACE that's fully covered. The others require special authority and failure on Ramipril. And when it comes to ARBs, patients have to have a cough on an ACE to be able to get coverage for an ARB. Looking at calcium channel blockers, again, they're first line with pretty good blood pressure lowering capabilities. As I mentioned before, you want to caution that combination of non-DHP, so your diltiazem and verapamil with beta blockers. And peripheral edema is quite common with these agents. So our options to help manage that would be to stop the medication, reduce the dose, or add an ACE or an ARB to help with that edema. But furosemide will not work, and this is a very commonly known prescribing cascade. So please, that's something to avoid. When it comes to beta blockers, they're not first line in adults over the age of 60. The ASCOT trials showed worse cardiovascular outcomes with beta blockers when used in the older population. We only want to use them if there's another indication present. So a recent MI, stable angina, heart failure, or AFib. When we have the opportunity, we want to choose cardioselective agents like metoprolol and bisoprolol, especially in patients who have asthma, COPD, diabetes, or heart failure. And when we are tapering, we want to do that slowly to prevent rebound tachycardia. So back to our patient. Against my better judgment, looking back now, we opted to have this patient track her vitals at home for a couple weeks until we got that chart to determine her other cardiovascular comorbidities. Because as many of you had mentioned, we would want to be careful not to exacerbate any underlying conditions that she may have or she may not have reported to us. So we did make some adjustments to the other medications. She said that she felt the miraviglin didn't help with her incontinence. The amitriptyline, she didn't really feel benefited her pain, so we suggested some dose reductions there. And when it came to her rabeprazole, she denied symptoms of GERD, so cut that down to every second day, thanks to Dr. Helm Schuris's last presentation last month. We made a plan to follow up in a couple weeks. From there, the MRP followed up a couple weeks later by phone, and the patient had reported systolic blood pressures of 70s to 80s, diastolics of 40s. She was very dizzy and lightheaded and was having quite a bit of hypoglycemia. So at that point, we stopped the agents that we would know that would not have cardiovascular benefit if she were to have heart failure, AFib, or something like that. So we stopped the hydrochlorothiazide, the amlodipine, and the trazocin, and switched her mixed insulin to an NPH because it is quite hard to titrate those mixed insulins. A few days later, her systolic blood pressure had risen to 100 and 110, and she had some improvement in her symptoms. And then 2 weeks later, her blood pressure was back up in the 130s over 70s and had resolution of symptoms. So the summary of her case is the antihypertensive deprescribing. We want to think about those possible comorbidities and pull things off in an orderly fashion. But in this patient's case, she was having significant issues with the number of medications she was on, so we had to pull those off quickly. We will continue to taper other medications as the patient's willing, like the amitriptyline, the rabeprazole, and the miraviglin. Just last week, we actually got the rest of her old records from her previous clinic. There was no other cardiac history noted, such as AFib or heart failure. So that made us question, is her beta blocker still indicated? Made us question the furosemide. Was that started because of an amlodipine-induced edema? We're not sure. Her PFTs that were reported were not indicative of COPD, so we questioned the ability to stop her inhalers. There was a note in her chart from a couple of years ago saying that she gave away her cat and noted that her coughing improved significantly at that time. Makes you wonder. And then finally, her antidepressant that was started for mild symptoms, is that still required after 14 years? So that's the summary of this case. Wondered if anybody had any other thoughts or suggestions they wanted to share.
Certainly, I think the beta blocker question is important because many of us have got into the habit of saying previous MI, specialists put them onto a beta blocker and they just stay on it. And I mean, there has been talk that prolonged use is a good thing, but I think that is the pendulum is swinging back now, saying, for the first year, it's great. And beyond that, if there are no other compelling reasons, why do it? And I mean, my understanding, it's not that effective in the elderly compared to the other medications that you've suggested. And there are side effects. I mean, people get short of breath and they can't, exercise and get a good heart rate. There are all sorts of things that can go wrong. So for me, it's always one of the first ones to try and get rid of if possible.
Absolutely. And any evidence that I've read recently, 3 years is kind of our maximum post-MI if there are no other indications. Now, is anybody aware of any other evidence, or what do you see commonly done in practice?
Well, Tom, at that recent therapeutics initiative talk that was very well done with our friend from the USA who was presenting there, he'd actually said that lots of the evidence was based on like the 80s and 90s. So the evidence seemed to be there, but it's just that our treatment has changed so much in the interim with revascularization, etc., which wasn't such an option at that point, that all those old studies, you shouldn't really be paying that much attention to them. And he was saying the same thing, a couple of years and there's no real reason to carry on. So that was pretty recent evidence.
Great. Thanks for sharing, Dr. Helm.
Yeah, if I could say something for a second, Sydney.
Of course.
I agree with you and Charles. I can't imagine in this person is wanting to take beta blocker. And it's easy enough to cut it in half, either once a day or half the dose twice a day, and then bring it off over a few weeks, and unlikely anything would happen. But I think this is an amazing case and important because I don't know, I made my student promise not to say anything, but I was quietly messaging him. I think he could get away with it. I bet he would agree that in teaching hospitals, it would be quite common still for somebody like this to go in with those drugs and come out with those drugs if the reason for hospitalization was, say, pneumonia or or a fractured hip or something. And in the last few years, I haven't seen anybody in medical records measuring the standing blood pressure, let alone the heart rate. I thought it was intriguing when you said in one of your first slides, we should always start by measuring. Yes, I'd like a copy of that slide. But I think also, I just put in the chat that from experience, it would kind of astonish me if this woman gets a useful analgesic effect from amitriptyline. She might like it for sleeping, but then she'd be sleepy in the day, and it could be causing her incontinence by making it impossible to empty her bladder. So I'd be very tempted to go further and try to get rid of the amitriptyline and the mirabegron.
Absolutely. This is a work in progress. I think we can get her down to maybe just one handful of medications.
I hadn't thought of it till starting to speak, but the mirabegron also might, if it relaxes the bladder sphincter, what does it do to the lower esophageal sphincter? Maybe it also contributes to quote-unquote GERD, as in heartburn.
Excellent thoughts. I'm just going to jump into case 2, but we can always come back and rediscuss case 1 if we've got some time at the end. So our second case here is a 90-year-old male with dementia. He had recent onset of severe grief where he was mourning the loss of his siblings over 20 years ago. This was quite distressing to the patient and the caregivers. So he was referred to myself by a family member because of possible adverse effects with the recent medication adjustment. So when I saw him, his record reported a history of hypertension and CABG in 95. He was on felodipine, ramipril, and ASA. For his dementia, he had recently been started on haloperidol, 5 milligrams, and a chronic quetiapine had been on for a couple of years now for agitation, as well as BPH with a history of Turpin 95 on tamsulosin. His family described that he was quite jovial, he had a sense of humor, and still had a personality despite having dementia, but all of that had disappeared since starting his haloperidol. He had significant sedation, he was quite dizzy and unsteady on his feet, and had mobility issues that weren't present prior. His home vitals, again, sitting, because we had his family members measure it at home and weren't able to get those orthostatic vitals. He had run out of ramipril over the last week and hadn't refilled it yet. So again, let's open it up and have some discussion. What would you do in this scenario? Tom, I think you're still unmuted.
I think the combination of haloperidol and quetiapine, those two in combination, my goodness, I wouldn't like to be on that combination. I think I'd feel terrible on it. And that seems to be what the family is talking about. And also with someone with dementia, blood pressure is 110 over 60 to 70. I mean, that's overkill. Why are we treating the blood pressure so aggressively? So of those, I think it's your choice as to which one to take away first. But I mean, either of those could go, because someone that's 90 and demented and we're aggressively treating blood pressure doesn't make sense to me.
Absolutely, but this just shows kind of that progression as people are younger and require antihypertensives. There are things that stay on. We don't necessarily take that opportunity to have that reassessment. So I think that's a big pearl from today is ask yourself every few visits, what's this medication being used for? Is it something that's still needed?
In the long run, he could be off probably everything. What do we treat, right? He had a CABG in 95. Does the aspirin really benefit him, right?
Absolutely.
And then the tamoxifen, I would reassess that too. He had Tupper in 95, also distant history. But yeah, in the end, he could maybe be medication free. And if he needed, I'm not sure if he has sundowning symptoms or gets worse, then intermittently something could be given, right?
Right.
But, yeah.
Any thoughts from the pharmacists or students on the line?
With his blood pressure that low and him not being on the ramipril, I would 100% tell the family, do not start the ramipril, because that's just going to lower it even more. And yeah, I think getting rid of the blood pressure medication because of the risk of falls, and tapering down the haloperidol and seeing what we can get rid of, because we don't know if he needs these medications anymore.
Absolutely.
So it's Rochelle. Oh, sorry. It's Rochelle here. I was, I'm a little more concerned about the haloperidol and the quetiapine. And then, of course, if you look at his home vitals, so definitely at a risk of fall and other things. So I would be very careful in even considering adding anything or changing, maybe some removals.
Absolutely. Thanks, Rochelle.
think,
Go ahead.
Yeah, I think I will want to, for me, all the medication need to be reviewed, because, looking at the vitals, I will want to take a look again and stop all the blood pressure and, monitor make sure I follow up and closely. I mean, she's 90 years old, so there's no need to be so aggressive in bringing down blood pressure. For one thing, this patient may actually have a normal blood pressure, but, so for me, those medication on blood pressure, I will want to, stop them and then follow and check the blood pressure. And then for dementia, there's no place for haloperidol except the patient is aggressive, but I don't know why, those haloperidol and quetiapine should be given to an elderly person at that age, which we know can increase our risk for falls and increase mobility and mortality. So for me, again, I want to, review those medications, those ones that are being used for dementia. And for tamsulosin, we will know that this one also has anticoagulant. So again, this will also increase our risk of fall. So in summary, the entire medication will have to be reviewed, and then we'll go from there. So it's not likely that it's going to benefit from all of them, looking at the way, going by the vitals and all these medications. So I want to review all the medications.
Great. Thanks, Dr.
There was, I think, an episode of aggressiveness, and when the haloperidol and quetiapine was initiated, he was a bit more aggressive also towards his wife, and that was the reason. But it was not re-evaluated. Normally, with anything where there is aggressive behavior, after 12 weeks, you should re-evaluate and taper off. And I think that opportunity was missed.
Great. Thank you. So in the interest of time, again, we can come back to this case. But I didn't do what I preached about checking those orthostatic vitals from the get-go. But that's very well something that could be happening with this gentleman, aside from the antipsychotic issue that we all identified. So just taking a brief detour here to discuss orthostatic hypotension. So that's when we have a sustained decrease in the blood pressure within 3 minutes of standing from supine or sitting. So the typical symptoms we see are dizziness, lightheadedness, and could be blurred vision. But some of those atypical symptoms could be syncope, dyspnea, and unexplained falls. So when we think about the causes of orthostatic hypotension, it can be multifactorial. We want to think about deconditioning, dehydration, whether that come from a disease, dialysis, or drugs, a dysfunctional heart, things like an MI or heart failure, as well as drugs are big causes of this. So of course, any of our antihypertensives can lead to orthostatic hypotension. Our beta blockers, about those non-selective ones, more so than the cardioselective agents, are alpha agonists and alpha blockers. So in this case, tamsulosin. Our diuretics are loop more so than our thiazides, and then a lot of non-hypertension medications as well. So our TCAs, amitriptyline, worse than nortriptyline, anti-Parkinson's agents, antipsychotics, trazodone, sedatives, opioids, all things to be aware of when we're assessing for orthostatic hypotension. When it comes to the management, we want to stop the medications of concern if that's possible, or at least reduce the dose. We want to consider a stepwise approach to tapering or discontinuing, starting with one agent at a time unless there are significant symptoms. Non-pharmacologically, what we can do to bridge that gap and help with maintenance of OH would be avoid having patients get up or moving too quickly, avoiding extra hot environments like hot showers, and for men, even sitting to urinate can help with symptoms. So looping back to our patient, over a couple of weeks, we actually tapered and stopped all of his medications. His blood pressure was stable, well below our target that we identified for this patient, less than 150/90, because of his age, his frailty, his dementia, and those troublesome and distressing behaviors that he was exhibiting prior were manageable with non-pharmacologic interventions. So yay, a moment of deprescribing wins. But of course, things always change. So there was some caregiver burnout reported, and the patient was quite restless at night. So we spoke with the family and opted to trial a non-antipsychotic agent just because of those cardiovascular and morbidity and mortality risks that come along with antipsychotics in dementia. So we started trazodone 25 at bedtime. And last that I spoke with the family, that's holding both the patient and the family quite well. And they found success in this deprescribing story. Before I turn it over to Jerome, just wondered if there were any final thoughts about this case. Oh, Tom, I think you have your hand up.
I think this is amazing, Sydney, but I think you, for temporarily at least, you emulated Shakespeare, the 7 Ages of Man. He came in as a baby, a newborn infant, mewling and with no drugs, and he was heading for going out. So but you've done pretty darn well. That's amazing.
And Val, who's I think on the line, gave this presentation in Fort St. John yesterday, and there was some discussion about that aspirin. Is that something that's still indicated because of his history of cabbage? For me, in my assessment, the patient had had a pretty significant fall while on haloperidol and beat himself up pretty well. So that aspirin contributed to a bleeding risk. So for me, and discussion with the family, that was something that we opted to stop. But again, we have to consider medications that can cause patients to bleed, especially if they're unsteady orthostatic hypotension and falling quite frequently.
And Sydney, I think Dr. Solomon had his hand up.
Oh, perfect. I can't see everybody's videos, so go ahead and take yourself off mute and speak up. I don't see anybody else looking to speak now, so I'm going to turn it over to Jerome, and we will have a bit of a conclusion here at the end. So Jerome is I don't know how that line got on the screen. Jerome is a community paramedic here in Dawson Creek, and he and I have worked quite closely with some of our elderly patients in monitoring of vitals and chronic diseases like diabetes, hypertension, and heart failure. And I thought this would be a great opportunity to have him come and speak about his practice and how he can support patients and physicians and other healthcare providers in the area. So Jerome, I will turn it over to you.
Thank you, Sydney. Good evening, doctors, nurses, and all the healthcare providers on the line. Especially thank you, Sydney, for inviting me to attend this session and have a chance to speak on the community paramedic program. So my name is Jerome Lake, and I'm the community paramedic in Dawson Creek, and I've been here now in this position for about 2 years. This whole community program started about 5 years ago with the approval from all the different health authorities in BC, obviously BC Ambulance, our union, and our Indigenous leaders around British Columbia. The community, there's community paramedics in most of the communities around the province now, so if you folks are not working with them, please reach out to them. We're here to serve you and the patients in our communities. Right? We're at your beck and call. So the whole program was implemented as a way to help to bridge some of the gaps in the healthcare system. The whole program was intended for seniors with the chronic conditions, COPD, CHF, hypertension, and diabetes. But since then, we've extended our scope to care for not only the seniors. We'll take on pretty much any challenge that you guys put out to us. It's a way that we can bring the healthcare system to our patients and hopefully allow them to remain in their homes and even live longer. As well as the chronic conditions, we are now working with palliative patients. We are moving into COVID testing, flu vaccinations, administration of vitamins as required. There's a number of other changes coming down the line for us, such as administration of antibiotics to the patient's home so they don't have to come into the hospital. We'll be able to go and take it to them. There's a number of things coming down the line, but as we know in the healthcare system, the wheels turn slow, right? So the whole program is based on 4 pillars. Community outreach and awareness, as getting us out into the communities, talking with the people, talking with the caregivers such as yourselves, to put ourselves out there to let you know what we can do and the fact that we're there to help you. Health promotion, number 2. So we're going into the schools, speaking to seniors groups, different organizations. We do training sessions, CPR for children and adults, child choking. We go into the schools to do to teach the kids how and when to call 911, proper hand washing, basic first aid. We do Narcan training. You know, the list goes on. One of my favorites is the wellness clinics, where we can actually go into seniors complexes, public venues, and set up and do vital clinics. We've done them at drugstores. We've done them in grocery stores. I do on an average of 4 to 6 clinics a month at different seniors complexes here in town. It gives the seniors, especially now with COVID on the go, it gives the seniors the opportunity to come in, have their testing done. It's recorded, it's given to them. I keep no records. Then if we come up with something, they can take the recording vitals and go and see you doctors so you can see what we've been tracking over the last couple of months, right? It's a great aid to you guys. Wellness checks, is we get a patient referred to us from some of the doctors here in town. I get them, get a lot from the community health, where we actually go into their homes. We do complete vitals, we do complete assessments, we document medications, we do safety checks, and any concerns that the patients may have, we document it. All our records are returned then to the healthcare team, and hopefully they're entered into the patient's files so you doctors have access to it so you can see what we see. We have a fantastic setup out there. It's called home health monitoring, and Sydney has mentioned continue monitoring how important it is to the clients. We have a home health monitoring system which is made available to us from TELUS, where we go in and we assess a referred patient, and if that particular patient meets the criteria, we'll place in their homes blood pressure cuff, a scale, a weight scale for somebody with CHF. We have SpO2 monitors, and we supply a tablet as all, no cost to the patient. The patients will log into the system on a daily basis. They do daily vitals. They answer a series of questions. Those vitals are then sent back to my computer. I monitor them daily. If I see discrepancies in blood pressures, weight gain or loss, the way they're answering their questions with shortage of breath, I'll make a phone call to the patient, and if I find it necessary, then I'll make a home visit and do a one-on-one assessment with them. All this information is available at the doctor's or the healthcare team's request. I can print off the daily vitals for up to a year at a time. And I have done here in Dawson Creek. I'll print it off. I'll do up a letter for some of the doctors here in town if need be, and I'll hand deliver the information to the doctor's office. And hopefully they'll review it and move forward with it. I've used this in communication with Sydney on a number of my patients here in town, especially with the blood pressures high and low or whatever the case might be. And Sydney has intervened on my part, and she'll deal with the doctors. And we've made some fantastic changes in some of these patients' lives. So again, in the community, we're all over the place. There's 2 in Tumbler Ridge, there's 2 in Hudson Hope, there's 2 in Chetwynd. I'm here by myself, but we're all over the province. So please, please use us. We're there for you, and we want to serve you and the patients, the people that need us in the community. So reach out, contact us. In closing, I want to thank you for giving me the opportunity, the chance to speak to you folks, and please use us. That's what we're there for. We're at your disposal. As well, we're also part of the emergency services. As you can see, I have a fully equipped Code 3 vehicle that I respond to reds and purple calls here in town to assist the team. So if anybody got any questions for me, let's do it.
Absolutely. Thanks, Jerome. I'm just going to do our final slide here, and then we'll open up to some questions and discussion. So our clinical pearls from tonight's presentation are basically individualize those targets. So you might want to consider more intensive blood pressure targets of a less than 135/85 in healthy older adults or patients with a significant stroke risk. Choose higher targets in older adults that might be at risk of adverse events, have limited life expectancy, or quite frail, and aggressive treatment just may not be desired by the patient. You want to evaluate for adverse drug reactions and orthostatic hypotension regularly. Consider other medications that might impact the blood pressure control. And when deprescribing, you want to consider medications that don't have other indications or known benefit first. So with that, I would like to thank you all for your participation and involvement tonight.